We will now proceed to the next session on vascular and cognitive disorders. To introduce the speakers is our moderator. She is the head of the Acute Stroke Unit in Pampanga Medical Specialist Hospital and a fellow of the Philippine Neurological Association. She took her fellowship training in stroke and neurovascular ultrasound in the University of Santo Tomas Hospital and her residency training in neurology and psychiatry from the same institution. She also graduated cum laude at the University of Santo Tomas Faculty of Medicine and Surgery. Ladies and gentlemen, let us all welcome our moderator, Dr. Maria Leticia Araulio de Jesus.
Good day, esteemed colleagues, distinguished guests, and friends. Welcome to our fourth plenary session. This session on vascular cognitive disorders will explore mechanisms, biomarkers, treatments, and holistic approaches to vascular cognitive impairment, offering insights that bridge science, clinical practice, and patient care. Our first speaker is a respected neurologist with extensive training and leadership in neurovascular medicine. She earned her Doctor of Medicine from the University of Santo Tomas, completed her residency in neurology at Makati Medical Center, and pursued training in neurosonology at Columbia Presbyterian Medical Center. She currently heads the Neurovascular Laboratory at Makati Medical Center, is a member of its stroke team, and serves as residency training head in the Division of Medical Education and Research. We are honored to welcome Dr. Ana Marie Sage-Nolido, who will deliver her lecture, Unraveling Vascular Cognitive Impairment, Mechanisms from Microvascular Injury to Blood-Brain Barrier Dysfunction. Our second speaker is an adult neurologist and dementia specialist, serving as president of the Alzheimer's Disease Association of the Philippines. He is a clinical associate professor at the UP College of Medicine, head of the Brain and Wellness and Memory Center at Asian Hospital and Medical Center, and a member of the Dementia Society of the Philippines. He also serves as consultant neurologist in various hospitals in Rizal Province. Please welcome Dr. Alvin Ray Cenina, who will present his lecture, Biomarkers in VCI, Early Detection, Prognostication, and Pathway to Interventions. Our third speaker is a neurologist specializing in dementia and neurocognitive disorders. He trained in neurology at Jose Reyes Memorial Medical Center and completed his fellowship in dementia at the Memory, Aging, and Cognition Center in Singapore. He is currently consultant and training officer at the Department of Neurology of JRR MMC, associate professor at Bohol Island State University School of Medicine, and is actively involved in advocacies for dementia care and research in the Philippines. We are privileged to hear from Dr. Steven Villaraza, who will discuss mechanism-based pharmacologic treatment of vascular cognitive impairment, targeting subcortical ischemic disease, executive dysfunction, and mixed pathology in Filipino patients. Our fourth speaker is a neurologist with subspecialty training in behavioral neurology and dementia. She earned her Doctor of Medicine from the University of Santo Tomas, completed her adult neurology residency at Makati Medical Center, and pursued fellowship training at the University of British Columbia Hospital in Vancouver, Canada. She is a fellow of the Philippine Neurological Association, Assistant Treasurer of the Dementia Society of the Philippines, and a member of the ASEAN Society Against Dementia. She heads the Memory Plus Center and serves as consultant at Makati Medical Center and other hospitals in Metro Manila. We are honored to welcome Dr. Donnabelle Shu, who will present her lecture, Holistic Management of VCI, Pharmacology Meets Lifestyle Medicine. As a reminder, throughout the lectures, a QR code will be flashed on the screen. We encourage all attendees to scan the code and send in your questions. These will be entertained during the open forum after all the lectures have been delivered. And now, to begin our session, may I call on our first speaker, Dr. Anna Marie Sage-Nolido.
So good afternoon, everyone. So everyone has already listened to the earlier lecture, and we all know the vascular dementia is the most preventable type of dementia that we know, and therefore knowing the mechanisms of microvascular injury and cellular damage is very important in targeting treatment. The outline of my lecture today is as follows. I will give an overview of vascular dementia. We will see how unique the brain vascular network is and what the neurovascular unit is and its role in causing dementia. We will then go to the mechanisms of neuronal injury, the core molecular mechanisms, which include the following: the endothelial wall dysfunction and blood-brain barrier breakdown. We will discuss oxidative stress, neuroinflammation and immune activation, impaired lymphatic clearance. So just a very brief overview, dementia is a global public health priority, affecting about 55 million people worldwide, a number projected to nearly triple by 2050. So vascular cognitive impairment and its most severe form, which is vascular dementia, represent the second leading cause, accounting for approximately 15 to 20% of all dementia cases. We all know there is a clear overlap between vascular and neurodegenerative contributions to cognitive decline as part of the aging process. And effective strategies for prevention and intervention of large vessel stroke has placed further emphasis on cerebral small vessel disease in combination with neurodegenerative mechanisms. So we all know that vascular dementia is not a single entity. It is actually a clinically and neuropathologically heterogeneous syndrome, and it is bound together by the fact that they are due to cerebrovascular disease. So we have many subtypes. We don't have to go through this, but just very briefly, we have post-stroke dementia. That is, if you have a single strategic infarct or multiple large vessel infarcts. And as we all know, the presentation is stepwise or abrupt cognitive decline following a clinical stroke. I will now go to the second, which is a subcortical ischemic vascular dementia, which is due to cerebral small vessel disease. And you will find it as having confluent white matter hyperintensities, and the presentation would be more insidious, gradual in progression, with prominent executive dysfunction, psychomotor slowing, apathy, and gait disturbance. We cannot also discount CADASIL, which is a very common autosomal dominant mutation in the Notch3 gene, causing vascular smooth muscle cell degeneration for young people. And of course, the mixed dementia, the combined vascular and Alzheimer's disease type, which is also very common in what we see with our patients nowadays. Very briefly, these are what we see in the neuroimaging. You can have a large stroke that affects a very large territory, embolic stroke that can cause dementia. You can have a strategic infarct that disconnects the cortical and subcortical white matter. You can have multiple infarcts, and you can have confluent infarcts, white matter lesions, but all of them will eventually cause cognitive impairment. So the question is, if we look at the MRI changes in our patients and classify them as mild, with just some punctate infarcts, moderate, more confluent infarcts, and here, severe, which is more, as we can see, as compared to the moderate, can we create treatment that match disease stages? What could possibly be happening microvascularly in the mild and in the moderate and severe neuroimaging changes? So we all know that we have the only treatment now that we know when it comes to preventing vascular disease is controlling the modifiable risk factors, diabetes, hypertension, dyslipidemia. However, when it already progresses to large and small vessel disease, causing significant infarcts and vascular cognitive impairment and dementia, it is very hard to reverse. And therefore, knowing the microvascular changes that happens during dementia it's very much important for us to actually make targeted treatments. So I'll start with what makes the cerebral vasculature special. So as you know, the brain, it demands 20% of our oxygen, but it's only 2% of our body. So why is it special? Why is the brain vasculature special compared to the lungs, the liver, or the kidney? Number one, it has a blood-brain barrier. So the endothelial cells are sealed by tight junction proteins, the claudins and the occludins, which are highly selective. In the liver, kidney, they have pores. But here, we are very tight junctions are very important. Number two, in the brain, you have the circle of Willis, which is the unique protective anatomy. If you obstruct one vessel, the brain has the capacity to collateralize. Another important is the neurovascular unit, which allows neurovascular coupling. So what is neurovascular coupling? The ability of the vessel to react to the needs of the nerves and the glial cells is very important, and it's very reactive. So if the nerve cells say we need oxygen, vasodilation occurs. We have autoregulation, maintains a constant blood flow to the brain. The brain also has a valveless intracranial venous system, which allows bidirectional flow to manage intracranial pressure. It also has extensive innervation, releasing vasoactive substances to control vascular tone. Another unique thing about the brain, which we have to know, is that the vascularization is outside in. The kidney, the liver, it's inside out. So what does that mean? So if you look at my pointer, in the cortical area of the brain, there is a proximal, middle, and distal vascularization. And these cortical vessels, which is just here, has no anastomosis between them. So any problem in circulation here will cause lacunar infarcts, and it is very, very significant in white matter disease. The deep white matter is also supplied here by terminal branches of the long medullary arteries. Also, again, end arteries. And that's why it's very prone to stroke. In the U fibers here, it is supplied by two: the cortical, initial fibers of the cortical nerves, arteries, and also the initial part of the deep medullary arteries. That's why it's very hard to find lacunar infarcts here. On the other hand, the thalamus, basal ganglia, as we all know, are supplied by perforating arteries from the brain stem parent arteries, and it's also prone to microvascular disease. So let's go to the very important brain vasculature and the neurovascular unit. So again, I mentioned, this is the cortical arteries which go deep. When you have the PL arteries here, it is composed of endothelial cells, the smooth muscle cells, and a perivascular space, which is very important, I will explain later, and around it are the glial cells. As you grow deeper into becoming an arteriole, you can see that the smooth muscle cells slowly disappear, and when they become a capillary, the smooth muscle disappears and you have pericytes instead. The pericytes are where the astrocyte and feet are actually attached. So this is what we call the neurovascular unit. It's very important in protecting the brain, and if there is any dysfunction, you will actually have strokes. So just a small, making it a little bigger, the vessel is here, and you have the endothelial cells and the smooth muscle cells. As you go deeper, nawawala yung ating smooth muscles and it becomes pericytes. But in the perivascular space, you have macrophages, which also play an important role when it comes to protecting the brain. So again, very briefly, not only is the artery very important, you have a venous circulation which also drains out, and anything around the perivascular space eventually goes to the lymphatic region of the brain, and all the waste products are washed out. Any obstruction or problem in the lymphatic system will also cause microvascular disease. So if you will look at that small area that I mentioned earlier, the neurovascular coupling area of the brain, you have the endothelial cells, you have the pericyte, you have the astrocytic end feet. The astrocytes are the ones that connect to the other microglia and oligodendrocytes of the brain. The endothelial cells are important for gene expression. The pericytes link the endothelial cells to the astrocytes, very important. So the link between the endothelial cells and the astrocytes. The astrocytes link everything to the other microglial cells. So the microglia, on the other hand, interacts through bidirectional paracrine signaling. So if they think there is a need, it produces signals which actually connect with other cells of the brain. And the oligodendrocyte precursor cells interacts and migrates along the endothelial cells and matures to myelinating oligodendrocytes, which, as we know, is very important for the nervous system. This is a very busy slide, but it just tells us that what happens is that this is the endothelial cell, this is the pericyte. So many transport systems are involved if you damage the area itself. So what happens? This is again the neurovascular cell unit. Anything that can damage that can cause blood flow problems. We need an intact unit for good flow. So again, good flow means good brain health. So what happens when you have lack oxygenation? So vascular risk factors cause large vessel and small vessel disease. It causes neurovascular unit dysfunction, which means the blood-brain barrier breaks down, oxidative stress occurs, there is neuroinflammation and mitochondrial dysfunction, which causes white matter neuronal injury, cortical and subcortical network disconnection, and vascular dementia. So what happens in vascular dementia? Briefly, number one, we will talk about endothelial wall dysfunction and blood-brain barrier breakdown. Under that, the loss of nitric oxide, modification of the tight junctions, aberrant angiogenesis, and changes in secreted factors. So important because these are the targeted treatments when we look for the management of patients with vascular disease. Then we'll go to oxidative stress, the role of impaired lymphatic clearance, neuroinflammation, and demyelination. As I mentioned, the endothelial cells is very important, and it has tight junctions in between that protect the brain. If you damage the endothelial cell, you lose nitric oxide. Reduction of nitric oxide causes restriction of vasodilation, so there's vasoconstriction. Nitric oxide also modifies the tight junction proteins via nitrosylation or nitrosation. So if you damage or decrease nitric oxide, you damage the tight junctions. And that's not good. The nitric oxide synthase dysregulation also causes a decrease in nitric oxide, causing vasoconstriction, endothelial activation, platelet aggregation, and leukocyte activation, all causing thrombosis. Endothelial dysfunction causes microbleeds. As mentioned, nitric oxide is important to keep the tight junctions intact. So if you damage the tight junctions, bleeding, the blood goes out into the parenchyma, and you have what we call the microbleeds. So the reason for the microbleeds is actually the dysfunctional tight junctions. So if you look at the endothelium in physiological conditions, it is the tight junctions is placed together by the occludins, claudins, and JAMs, the VE caderins, PCAMs, and CD99. Whenever there is dysfunction, which I will show here in the next slide, what happens? Any dysfunction, problem, inflammation causes disruption in the tight junction. So the vascular endothelial growth factor stimulates the VEGFR2 receptors, causing internalization and degradation of the cells. Cytokine also increases due to TLRs affecting the NFKB. So cytokines stimulate metalloproteinases to occur, causing matrix degradation, angiogenesis, and leukocyte transmigration, which I will be talking about later more. No? So in general, what happens, there is dysfunctional tight junctions, cells start migrating out, and you have what we call microbleeds. So this is what you see in patients who have problematic tight junctions. And these are actually one of the targets for treatment and prevention of microvascular disease. Aberrant angiogenesis. Every time, when there's dysfunctional endothelium, vascular end growth factor is released, dysregulated angiogenesis. These vessels are not like the normal vessels. So they are not good, what you call neurogliovascular units. And that damages even more, damages neurovascular coupling, and continues to damage the entire cells, and causing problems in the blood-brain barrier. Also, when you damage the endothelium, you start releasing von Willebrand factor, heat shock protein 98, sphingomyelinases, also again targets for treatment, and this causes further vessel damage and white matter changes. So metalloproteinases, usually when released, damage the endothelium, the lipids, the lipid-rich necrotic, so cellular matrix is degraded, lipid-rich necrotic cores are degraded, and it causes more thrombosis. Vascular Willebrand factor is protective initially for platelets, but when you damage the endothelium, you create a different type of von Willebrand factor. It increases platelet leukocyte adhesion, increases inflammation, and atherosclerosis is exacerbated. So it's a different type of VWF. So just pathological, what happens in the small vessel disease. I think it's just a summary. I don't have to go through this. And what happens? This is a healthy blood-brain barrier. You can see in a blood-brain barrier of patients with small vessel disease, everything is detached. And that is not good because the blood vessel does not have the ability to compensate. So, oxidative stress. In vascular disease, chronic hypoperfusion-reperfusion cycles in the microvasculature create a state of metabolic stress leading to overproduction of reactive oxygen species and reactive nitrogen species. We all know about static autoregulation. I don't have to go through this. We have dynamic autoregulation that whenever there is an increase in blood pressure, you increase blood flow. Whenever there is a dysfunctional autoregulation caused by the hypoxia, vascular stiffness, temperature, vascular risk factors, hypoperfusion or ischemia happens. You can have syncope, hyperperfusion, microvascular problems, and loss of blood-brain barrier integrity. And all of these will lead to cognitive dysfunction. So whenever you have hypoxia, oxidative stress is actually caused by hyperactive glial cells. So the glial cells all over the brain, the microglia, the oligodendrocytes, the astrocytes start releasing prooxidants, reactive oxygen species, and cytokines, causing damage in the vessels, causing leukocyte migration, and eventually atherosclerosis. Third, neuroinflammation and immune activation. When you have hypoxia, what happens? You lose oligodendrocytes and you have abnormal expression of aquaporin 4 in the astrocytes. So you damage the myelin, you damage the astrocytic feed. Aquaporin 4 in the astrocyte is very important. No? They learned that it is one that actually removes the waste products that are released in the perivascular space. And therefore, if you have a problem there, you can actually have microvascular problems. So hypoxia causes the release of reactive oxygen species, which damages the mitochondria, releasing damaged activated molecular patterns, which stimulate resting microglia to become activated, releasing pro- and anti-inflammatory cytokines, inducing release of peripheral leukocytes, damaging the brain, and it becomes actually a cycle. So just seeing here, vitamin D actually reduces neuroinflammation. So white matter injury, oligodendrocyte death, and demyelination. Oligodendrocytes have a high metabolic rate and limited antioxidant defenses. So inflammation, ROS, and excitotoxicity triggers oligodendrocyte apoptosis. So oligodendrocyte precursor cells maturation and are impaired, and it prevents remyelination. And demyelination disconnects cortical and subcortical region. So what happens? If you have hypoxia, there is failure of autophagy. Autophagy. So autophagy actually is the ability of the cell to break down and remove waste products, and autophagosomes are produced. You also impair the ATP levels decrease, calcium accumulates in the cell, and that causes calcium-dependent protease activation, again, causing destruction of the oligodendrocyte, and that damages the nerve. So it's a vicious cycle. Last mechanism is lymphatic dysfunction, impaired lymphatic ways. We all know that the lymphatic system, there are areas, the CSF from the paraarterial space flows into the extracellular matrix via the aquaporin 4 channels of the foot processes of the astrocytes. The way CSF goes out to the venous region and eventually is removed through the lymphatic or the lymphatic system. In cerebral microinfarcts, there is a problem in the lymphatic system. They cannot drain. And that also is what happens in CADASIL. So in CADASIL, they noted that there is accumulation of waste molecules or small micromolecules around the lymphatic region in the perivascular space, and that impairs the drainage coming from the astrocytes. When that happens, it destroys the cells. And that also happens in cerebral amyloid angiopathy. So their brownish granules accumulate around the endothelial cells, and that impairs lymphatic drainage. So again, present treatment is to control risk factors. But what happens, no? Reduced cerebral blood flow, brain barrier dysfunction, trophic failure, immune dysregulation, reduced clearance, eventually causing hypoxia, altered brain homeostasis, cell dysfunction, oxidative stress cytokines, and altered proteostasis, and then eventually cognitive impairment. The next lectures will probably talk about what happens and how to target these changes in order to prevent microvascular disease. So is controlling risk factors enough? The correct order of vascular disease progression needs to be understood because it helps researchers find optimal treatment times and create treatments that match disease stages. So the molecular sequence of events follows a standard pattern, but the time course depends on the degree of vascular injury and individual resistance factors. So the diagnosis relies on the combination of clinical assessment and crucially the neuroimaging. And the development of reliable biomarkers is a major goal to improve diagnostic accuracy, track disease progression, and serve as surrogate endpoints in clinical trials. In conclusion, vascular cognitive impairment is considered the most preventable form of dementia. The unique outside-in vasculature of the brain explains why some areas are more susceptible to infarction. And the neurovascular unit, through neurovascular coupling, controls local blood flow in response to neuronal activity, vital for energy-dependent brain functions. And by understanding the mechanisms of neuronal injury from endothelial cell dysfunction, oxidative stress, neuroinflammation, demyelination, and lymphatic drainage impairment, molecular strategies and therapeutic targets may be developed. So with that, I would like to give the floor to my fellow lecturers to talk about biomarkers and neuroimaging. Thank you very much.
Thank you, Dr. Ana Marie Sage-Nolido. And now let us welcome our second speaker, Dr. Alvin Ray Cenina.
A pleasant afternoon to everyone, and thank you to PAVIN for this kind invitation. And hopefully we'll have a lot of learning this afternoon for this cognitive impairment in vascular disease. Okay, so the task that I need to discuss with everyone this afternoon is about the biomarkers in vascular cognitive impairment. Okay? This is my disclosure. So for the outline for this topic, first we'll go through the VCI terminologies, neuroimaging as the established biomarker, blood and other biomarkers may be coming soon, and the cognitive biomarker profile. So there are a lot of terms, and sometimes we might be overwhelmed with these different terms, no? The DSM-5 uses the term neurocognitive disorder, with mild being MCI and major as dementia. And the VICCCS criteria says that we can also classify VCI into mild and major, and then subclassify as post-stroke, subcortical ischemic vascular, multi-infarct, or maybe mixed type of dementia. Mixed meaning not necessarily only Alzheimer's, but also other pathologies that can be mixed with vascular pathology. And we can still use some of the terms that are used before. And then, but to simplify things, we can use the general term VCI. So vascular, because it's connected to vascular diseases, and cognitive impairment may be MCI or dementia. The VASCOG-2 WSO criteria of 2025, thank you, Ma'am Enkar, for highlighting this earlier. So, mas magiging mabilis na po ko dito. So, VCID, or vascular cognitive impairment and dementia, encompasses both MCI and the stage of dementia. So, again, overview. MCI, the general definition for any MCI, it's acquired. There's a subjective concern, there's an objective deficit, and there is no functional decline. And in dementia, there is functional impairment. And we remember all the different cognitive domains, including attention and processing speed, executive function, learning and memory, language, perceptual motor, and social cognition. So when do we presume that this cognitive impairment is due to vascular etiology? Either two factors, temporally related to a stroke, which is usually abrupt in onset and persists for more than 3 months. And there is a documented history of that stroke, and there are other neurologic deficits attributable to that stroke. If there are no clinical strokes, sometimes the onset might be more gradual and slowly progressive, and the main deficits may be in attention, processing speed, and executive dysfunction. Some supportive features include mood lability and gait balance disorder. So again, highlighting that in vascular cognitive impairment, 1 and 2, processing speed, attention, and executive function are mainly affected. And in terms of the temporal relationship, so in A, there is immediate onset of dementia after the stroke, or in B, there's a later development of dementia after the stroke. So in C, this is multi-infarct dementia. And in D, now in case of D, it's more difficult to establish the connection between the stroke and the onset of dementia. And then E, you have background small vessel disease in a patient developing progressive dementia over time. So the importance of neuroimaging, so in the definition, there should be an infarct. It could be multiple, it can be one but strategic, or it can be a large infarct that affects cognition. There can be multiple lacunes, at least 2 or more outside of the brainstem, or it can be a one strategic lacoon, maybe in your thalamus, or a lacoon in the background of a severe confluent white matter hyperintensity. So in WMH alone, it should at least be severe, periventricular, or moderate to severe deep subcortical. or if it's a bleed, large, lobar, or also strategic. Some supporting features include your microbleeds, superficial siderosis, and CAA. So this is just an illustration of our various findings in neuroimaging. And as you can see, in terms of cerebrovascular disease, both small vessel and large vessel can produce our dementia. What if there are other features that may say that maybe there's other predominant etiology? So exclusion criteria, history of suggestive of AD, DLB, PDD, or other neurologic disorders, and especially if there is minimal or absent lesions on neuroimaging. And the third exclusion factor is that the presence of biomarkers for other conditions, like, again, AD, Lewy body, or it's maybe a tumor causing the cognitive impairment. And in terms of VCI, for level of certainty, it's either probable or possible. Probable if you have clinical features that are consistent, plus the presence of neuroimaging or a genetic evidence. So possible only if we don't have the other imaging features. Of course, VCI can be mixed or multiple. The reasons, there may be a co-pathology with AD, meaning the patient or the case will fulfill the criteria for both. So it can be co-mixed AD and VAD. And we know that in patients with dementia, there are likely more mixed pathologies as the cognitive impairment worsens. So mas maraming pathologies in this particular study. So with more pathologies, your cognitive impairment is actually worse. And ang isang relatively new feature of this new criteria from VASCOG is that they are highlighting the presence of preclinical or at-risk VCID. Siguro po, marami po sa atin, patient na may headache, nagpa-MRI or CT, and then voila, ang daming vascular lesions without any cognitive symptom. So this is that patient. So preclinical siya, at risk siya, but wala pa siyang cognitive impairment. So supporting feature is marami pala siyang background risk factors, dementia, hypertension, etc. So this is another illustration of what Dr. Nolido explained earlier about the risk factors and the mechanisms underlying that, which eventually lead to our cognitive impairment. So let's go to the imaging biomarker. So again, this is an old slide highlighting multi-infarct, small vessel, hypoperfusion, or hemorrhagic types of dementia. And for our trainees, what are your strategic types of infarct? Either thalamic, ACA, PCA, a lesion in your angular gyrus, or basal forebrain. So those are your some categories of your vascular lesions. So as an update in terms of imaging biomarkers in this review, so all of these imaging biomarkers and emerging imaging biomarkers can be analyzed in terms of clinical context, in terms of the functional assessment of the patient, and other biomarkers. So for our trainees, so the definition, the imaging definition of different vascular burden from a recent small subcortical infarct, obviously DWI is very useful. A lacoon, which has an hyper-intense rim compared to your perivascular space. Your white matter hyperintensity, which has a relatively indistinct border. Your cerebral microbleeds, which GRE or SWI is very important. as well as your superficial siderosis, and the microinfarcts, which a higher level Tesla MRI will be better at detecting. So why should we look at this in patients with neurologic conditions? Because they have an impact in terms of atrophy. So for example, in this relatively young patient, 55-year-old with confluent white matter changes, after 36 months, you can see visually the significant atrophy in the posterior regions of the brain. So what can we apply in our clinics right now in terms of the imaging biomarkers? So we can use the SVD score, small vessel disease. So what does it incorporate? The WMH, lacunar, perivascular space, and microbleeds. So for each one, there is just 1 point, simple. My lacunar, 1 point. My microbleed, 1 point. My moderate to severe perivascular space, 1 point, and may moderate to severe WMH, 1 point. To illustrate that, so these are considered severe perivascular WMH or moderate to severe deep subcortical white matter hyperintensity. So for the enlarged perivascular space, so these are some of the illustrations, specifically at the level of the basal ganglia. So apparently binibilang, no? So if there are 11 to 20 enlarged perivascular spaces, then that's considered at least moderate, and then up to severe kung more than 40. So basta moderate to severe, that's considered 1 point. Bakit natin bibilangin? Because SVD score of 3 or 4 is considered or categorized as severe. Some components of the SVD score, age and high blood pressure, increases small vessel disease burden. The SVD score also prognosticates the worst MRS for patients after the stroke. And in this particular study, it is the SVD burden is associated with poor processing speed and global cognition. In another study, they looked at worse global cognition, executive function, and visuospatial function in patients with higher SVD burden. And in this particular study, they modified a more detailed SVD score, and they noted a higher diagnosis of VCI in these particular patients. So the global SVD score can predict vascular dementia and even all type of dementia, but better with predicting vascular dementia. And again, in this particular study naman, consistently global cognition and executive function are more impaired with higher SVD scores. In this next slide, again, they are looking at the higher SVD burden with worse cognitive scores and worse MRS. And they noted that if you're just looking at the clinical factors, less yung kanyang predictive ability versus a detailed SVD burden score, which can predict cognitive and functional impairment after 1 year. And we know that the cholinergic disruption is one of the main bases of this impairment. So now, that's what we can use in our clinics right now, the SVD burden. What are potential imaging biomarkers that we can use maybe in a few years or a decade or so? So all of this that we are looking, visual yung ating rating, but they can be automated for rapid quantification, for volumetric analysis, and that's where several studies like this are looking at. We'll not go into the details, but the point is AI and machine learning will help us quantify this better. And these techniques will make it more personalized, but the challenge is standardization, generalizability, and some ethical considerations. Cerebral blood flow can also be evaluated in our MRI using the arterial spin labeling technique. looking at tissue perfusion, and these are some of the things that can also be added in the MRI protocol. And also the structural MRI is just one factor, and then the functional MRI, which measures the functional connections of the different networks. So they are looking at the different, applying also the resting state fMRI in patients with VCI. And these different parameters of neuroimaging can be evaluated ng pagsama-sama, multimodal, because predicting them we will need all the information that we will get. So there are different types of imaging parameters, and then we can summate that and produce something that will be predictive of cognitive decline for our patients. How about blood biomarkers? So emerging, wala pa tayong routinely used at this time specifically for VCI. I use this particular paper to highlight some of this. So amyloid beta 42/40 ratio is actually also useful in VCI because cerebral ischemia can actually induce more amyloid aggregation, and the amyloid then produces more inflammation and neurodegeneration. So AB42/40 ratio can be also useful for patients for VCI. Another blood biomarker is neurofilament light chain, which is indicative of neuronal axon damage. No? So with more brain injury, then you have more NFL. The S100P reflects glial injury damage. That also is increased in patients with VCI. Some of the other parameters may need further investigation. So this paper is looking at specifically NFL and GFAP. Actually, these terms, ang naalala ko lang nung nagre-review ako sa histopath, the neuro-onco guys probably are familiar with this. So NFL, GFAP, they are associated with vascular brain indices of white matter injury. No? So again, white matter injury, and it looks like NFL is really more connected with white matter hyperintensity and vascular health. How about inflammation? So there are different inflammatory markers that were looked at, and it looks like interleukin-6 is better at differentiating between vascular dementia and Alzheimer's disease. Tumor necrosis factor alpha may differentiate VAD with controls but not versus Alzheimer's disease. CRP was not significant. EEG may also be a neural synchronization biomarker, but obviously it's not specific for VCI. Transmagnetic stimulation can also be used as a neurophysiological biomarker because there is enhanced cortical excitability in the motor cortex as a compensation for ischemic damage and neuronal loss. So, after all of that, we can have a cognitive biomarker profile in a patient we are evaluating. So, for example, this might be what will be done in the next several years. So, all of this information, clinical, neuroimaging, and biomarker information will be integrated into a program, and then it will give us a predictive factor for that specific patient. So for example, in this particular study, what they compared is their program, their AI machine learning program, versus the average neurologist. So ang sabi dito, the program was better against the average neurologist in predicting or diagnosing VCI. So again, to summarize that, this is one of the useful graphical abstracts from one of the papers I presented. So we have our clinical information, our functional assessment, and the neuroimaging plus future biomarkers, so we can come up with a biomarker profile for our patient looking at the different pathologies that will contribute to cognitive impairment. So as of now, we know that A-beta 42 and 40 and amyloid PET are our core AD biomarkers, along with p-tau217, and we have I gave an overview about the following biomarkers that may be useful for our patients with vascular MCI. So what can be done today? Of course, our clinical evaluation, our neuroimaging, and what we can already use our SVD burden. And our blood tests are mostly for our risk factors and medical factors that impact on cognition. But tomorrow, maybe with biomarkers, we will have more advanced imaging incorporated and blood biomarkers for co-pathology and CNS injury, so that biomarkers will make diagnosis more personalized. We can be better at stratifying patients, prognosticating, and to intervene earlier. That's the point naman for our biomarkers. So we can prevent dementia. So if we all know this, how to prevent dementia and what is good for brain health. But kapag na-stratify na natin yung patient, then we will be more strict about these prevention parameters. And this is what we have discussed in the past 21 minutes. And thank you.
Thank you, Dr. Alvin Ray Cenina. And now, let us welcome our third speaker, Dr. Steven Villaraza.
Okay. A pleasant afternoon to everyone. So I will be discussing about the mechanism-based pharmacologic treatment of vascular cognitive impairment, specifically focusing on subcortical ischemic disease, executive function, and mixed pathology. Now, I want to ask a very important question. I want you to spot the difference. Okay, I'm going to give you 10 seconds, as a timer would allow. I want you to tell me where are the differences. Okay, ready? Can you spot the differences? Mahirap. Okay. 5 seconds? Okay. Sige. I promise at the end of this talk, I will teach you a fast way on how you can find all of the differences within 15 seconds. Okay? But let's first go to the topic. Okay? So we're going to talk about vascular cognitive impairment, and this refers to a spectrum of vascular brain pathologies that contribute to any degree of cognitive impairment. As what Dr. Ampil, Dr. Sage-Nolido has mentioned a while ago, it ranges from your subjective cognitive decline, SCD, to mild cognitive impairment, MCI, up until your vascular dementia. Now, when it comes to dementia, the most common cause is still Alzheimer's disease, and vascular cognitive impairment is the second most common cause of dementia. And according to the WHO, 47 million will have dementia by the year 2050, and 30 to 40% of which will be associated with cerebrovascular disease. So when we talk about cerebrovascular disease, we're talking about cognitive impairment due to either stroke, cerebral small vessel disease, or mixed pathologies. And this is where the different types of your vascular cognitive impairment would fall under. So we're familiar with the cognitive impairment due to stroke, and this is classified as your large vessel infarctions or your post-stroke cognitive impairment. The presence of large vessel stroke has strong association with the development of cognitive impairment and would usually appear within 2 to 6 months after the stroke. So the cognitive impairment is usually overt. Now, cerebral small vessel disease, the lesions would come in the form of either your lacunes or your white matter hyperintensity. So for the lacunes, this might be due to these are produced due to insufficiency in the deep penetrating vessels. Whereas for your white matter hyperintensities, other old literatures would refer to this as your leukoariosis. But currently, we are using the terms periventricular and deep white matter hyperintensities to refer to this entity. It reflects reversible increase in the interstitial fluid, usually in the early form, or they might be due to demyelination or axonal injury in the late form. And usually, the cognitive impairment here in this type might be covert or subtle. And when it comes to mixed pathologies, we're referring to entities such as caused by your cerebral microbleeds, as we see in your CAA, right? CAA-associated pathologies, okay? Wherein an increased number of your cerebral microbleeds increases the risk for developing cognitive impairment. And for these types of pathologies, the cognitive impairment might be overt, might also be covert. Now, my talk will be focusing on cerebral small vessel disease. And why do we need to focus on cerebral small vessel disease? Because when you look at the data, for stroke, around 11% of your vascular cognitive impairment will be attributed to your large vessel infarct. Another 15 to 40% will be due to your mixed pathologies. But strikingly, around 70 to 80% of your vascular cognitive impairment is due to cerebral small vessel disease, whether by your lacunes, around 8 to 10%, and your white matter hyperintensity. So when we're talking about vascular cognitive impairment, we're quite familiar of the post-stroke cognitive impairment or post-stroke dementia. But what we should be more aware of is that the most common form of your vascular cognitive impairment is due to your white matter hyperintensities and your lacunes. And we can further group these into your, what we call your subcortical vascular cognitive impairment. Okay? Now, since we're going to talk about the mechanisms of treatment, I would just like to re-emphasize the different mechanisms on how these subcortical lesions produce the cognitive deficits. So the first stage would be primarily due to reduce in the blood flow. So here, hyperperfusion is a key driver. It's also exacerbated by other chronic conditions such as your hypertension and diabetes. And the primary pathologies at this stage would be development of your arteriosclerosis, lipohyalinosis, and fibroid necrosis. And these pathologies would produce increased stiffness and eventually decreased cerebral blood flow. And this will also alter or decrease your cerebral autoregulation. Now, after this, then this is where your microvascular injury would come into play. With the presence of chronic hypoperfusion, this will directly affect the synaptic transmission and neuronal function. So it involves important regions such as in your white matter and in your hippocampus. Now, in this stage, there's a release of your, what you call your HIF, or your hypoxia-inducible factor 1A, which actually promotes an inflammatory pathway. So here at the bottom, you can see that the release of your HIF would induce the production of your FIR gene, which will eventually increase the production of your MMPs. And the MMP will either produce blood-brain barrier breakdown, demyelination, edema, and release of your endothelin-1, which further induces vasoconstriction. Following this is now where your different biomarkers would come out. So once you have your microvascular injury or pathologies, then this is where your lacunes and white matter hyperintensities would appear in your neuroimaging. So white matter hyperintensities demonstrate degeneration of the myelin sheath and axons, oligodendrocyte degeneration, but no infarcts or cystic necrosis. Whereas for the lacunes, there's occlusion of their perforating vessels, either to the thalamus, basal ganglia, internal and external capsules. So again, this would reflect your strategic infarct, cognitive impairment. And this is where, this is the most important, I would say, descriptor for vascular cognitive impairment, because these are the areas wherein the lesions would produce disruptions in your prefrontal subcortical and in your thalamocortical circuit. All right? And that's the reason why the initial or the primary manifestation of your vascular cognitive impairment is usually executive dysfunction. Following this, there will be a reduction in your synaptic plasticity. So synaptic plasticity is the ability to adjust the structure and the strength of the synaptic connections, either via your long-term potentiation for enhancement of the signals or long-term depression or weakening of the signals. So when you have small vessel microvascular injury, the ability of the neurons for synaptic plasticity goes down, right? And in VCI, what happens is that there's a reduce in the number of synapses, decrease in the strength, and production of abnormal synaptic morphologies. So this eventually weakens the neural network and causes further loss of information processing capabilities. And lastly, this would now produce the cognitive impairment. So here, patients would now start to experience problems in planning, decrease in focus, ability to initiate tasks, regulate emotions, and even manage time. Plus, if there are other areas of the brain that would be affected, they will also have presence of stepwise neurologic deficits such as your hemiparesis, dysphagia, dysarthria, pseudobulbar palsies, emotional incontinence, urinary incontinence, or even Parkinsonian features. Some would even have behavioral abnormalities such as disinhibition and akinetic mutism. So here you can see that there's a stepwise or, again, a predictable flow in the mechanism and mechanism to injury in vascular cognitive impairment. And if we're going to try to summarize, if we're going to have one word to describe these mechanisms, there will be initially a macrovascular pathology, leading to microvascular pathology, leading to neuronal or glial pathologies, synaptic, finally leading to your cognitive and functional disorders. Okay? And this is where the treatment would come in, because if we're now able to identify the different stages of the the production of your pathologies, then this is where the different pharmacological targets can focus on. So this is a list, although the image is not clear, of the current pharmacological therapies that are available right now for vascular cognitive impairment. So the upper half would include those with current treatment evidences, and the lower half would be those that are still under development or still under research. Okay, so I'll just briefly go through the treatment modalities. Of course, we're familiar with donepezil. It's a non-competitive reversible cholinesterase antagonist. Has limited binding to your butyryl cholinesterase. So there are, for vascular dementia, there are 3 RCTs that have shown that donepezil, 5 and 10 milligrams, can significantly reduce the rate of cognitive decline as measured by your ADAS-Cog. Of course, with a higher dose of 10 milligrams providing the most significant reduction in the cognitive decline. For galantamine, there are only 2 RCTs for vascular dementia. So for the 12 milligrams twice a day, it has also shown significant reduction in the rate of cognitive decline. For rivastigmine, small, clinically insignificant positive effect measured by MMSE for the 12 milligram dose. Now, we have here the 3 cholinesterase inhibitors, and it seems that donepezil has the strongest evidence for treatment of vascular dementia. And the reason for this has been attributed to its longer half-life as compared to your galantamine and your rivastigmine. Next would be your memantine, which is a non-competitive NMDA receptor antagonist, which limits excitotoxic neuronal damage. For vascular dementia, 2 RCTs are available, showing that the 20 milligram dose can significantly reduce cognitive decline as measured also by the ADAS-Cog. Butylphthalide is a key chemical in celery oil, contributing to its flavor, and is commonly used as in your traditional Chinese medicine. It is attributed to have anti-inflammatory properties, improved mitochondrial function, diminished platelet aggregation, reduced oxidative stress, and prevention of neuronal apoptosis, and has been approved in treatment for China for acute ischemic stroke. So for vascular dementia, there are 4 RCTs for this molecule, which also shows significant reduction in cognitive decline as measured by the ADAS-Cog and the MMSE. So the dose recommendation for this molecule is 200 milligrams 3 times a day. Ginkgo biloba, specifically your EGB761, given from a range of 60 to 240 milligrams per day, commonly used also as a type of treatment in your traditional Chinese medicine, with the following anti-inflammatory properties and antithrombotic properties. There are 9 RCTs for all-cause dementia that has shown positive effect in cognition as measured by your ADAS-Cog and your SKT, or your syndrome Kurtz test, which is similar to what we have in the MOCA in Germany. So a dose of 240 milligrams per day has shown some, at least, positive reduction, reduction in the rate of cognitive decline. But this effect is more seen in patients with Alzheimer's disease than with vascular dementia. Cerebrolysine is a pig-derived enzymatically treated peptide, including your BNDF, GDNF, NGF, and CNTF, and has regulatory approval for the use of stroke in Russia, China, South Korea, Austria, and Germany. For vascular dementia, there are 2 RCTs that have shown that 30 ml per day has a significant positive effect on cognitive function as measured by your MMSE. Nimodipine is a calcium channel blocker with central vasoactive properties. However, studies in combination with galantamine or galantamine alone, so it's combination of nimodipine and galantamine versus galantamine alone for mixed dementia, did not show any additional benefit for the cognition. What about antihypertensive? So it has been established that midlife hypertension is a risk factor for vascular dementia and all forms of other dementias. And there are 5 RCTs for all-cause dementia showing that significant control of the blood pressure reduces the risk for dementia. And when you talk about the the degree of control, the lower that we're able to put down the systolic blood pressure, the dementia risk further goes down. Lipid-lowering therapy, little to no direct clinical trial evidence. There are no RCTs looking to specifically for vascular dementia as a primary outcome, but there are 2 RCTs that looked into all-cause dementia as an outcome, and they found no associated additional benefit for risk for reduction of developing dementia. However, meta-analysis of 31 observational studies showed substantial reduction in the risk for non-Alzheimer's disease type of dementia, wherein greater doses of statins also conferred higher risk reductions. What about antihyperglycemics? So we have type 2 as a common risk factor for vascular cognitive impairment and dementia, and it increases the risk for VAD by around 137%. So metformin was associated with reduced risk of cognitive impairment, as well as the newer molecules, your GLP-1 receptor antagonist, also has shown to reduce the risk for developing cognitive impairment. So those are the molecules that have established evidences. Now let's look at those that still are under development. So methylphenidate, a noradrenaline and dopamine reuptake inhibitor, which is primarily used as a stimulant for attention deficit disorder. There's one pilot study that has demonstrated that a single dose of methylphenidate improved executive function and verbal memory. But these are for patients with a post-stroke cognitive impairment. Actovergin is developed from calf blood that has been ultra-filtered, purified, and deproteinized. So mechanism here is it improves plasma membrane transport of glucose and tissue oxygenation. So it has been used as drug for performance enhancement in sports. So if you're familiar with Lance Armstrong, this is one of the medications that were associated with him. Okay, so in the Artemida trial, wherein they recruited post-stroke patients, a single dose of 2,000 milligrams per day of Actovergin followed by daily doses of 1,200 milligrams improved cognition as measured by the ADAS-Cog. Apabetalone inhibits bromodomain and your BET proteins, okay, and reduces harmful gene expression of chronic diseases. So here, they recruited patients with type 2 diabetes, low HDL, and recent history of ACS, and they were given apabetalone 100 milligrams twice a day. The subgroup of patients have shown improvement in their MoCA scores, but this improvement was only demonstrated in those with low MoCA scores at the beginning, whereas those with higher MoCA scores did not have any improvement. So if we're going to somewhat summarize the different drugs that are available for the treatment of subcortical vascular dementia, if we're going to put them in parallel with the different mechanisms, we can see that at least for the macrovascular pathologies, you can use your EGB761, antihypertension management, probably statins, anti-diabetic medications. For your microvascular, your EGB 761, antihypertensive and anti-diabetic medications. For the neuronal and the glial level, you have your butyl phthalate. In the synaptic level, of course, this is where your donepezil, memantine, galantamine, rivastigmine, and cerebralizing would come in. And for the cognitive and functional level, your donepezil and your memantine. So when you look at it, when it comes to the cognitive and the functional symptoms of dementia, we are actually targeting the disruption in the synaptic and in the cognitive functional level. So this leaves us with a lot more options in controlling the micro and macrovascular risk factors, which I think will be later discussed by Dr. Donnabelle Chu. So, in summary, subcortical vascular dementia is the most common form of vascular dementia characterized by the presence of your lacunes and white matter hyperintensities. Your subcortical VAD involves a complex but interrelated chain of pathomechanisms from macrovascular to the synaptic level, producing your clinical symptoms of cognitive deficits and dementia. So executive dysfunction is due to the disruption of the prefrontal, subcortical, and thalamocortical circuits, which is actually the area which is very, very dependent on cerebral blood flow. And effective pharmacologic therapy in the subcortical vascular dementia involves targeting key mechanisms within that cascade, as what we have demonstrated. So why did I ask you to spot the difference a while ago? Because Alzheimer's disease has this typical clinical trajectory. So it's a gradually progressive cognitive decline. Patients would usually present with mild memory issues that later would develop into more perverse memory loss. And when we look at subcortical vascular dementia, it also has the same trajectory. No? Chronic progressive with mild symptoms. Later, the symptoms become more perverse or more severe. So they actually look quite a lot similar to one another, right? And I think that's the reason why they might look like they might look a lot like one another, but when you look at the mechanism, there are some mechanisms that are present in subcortical vascular dementia that can be distinctly associated with it and can be treated. Okay? So, lastly, balikan natin yung spot the difference. So how do you know? How do you check if you're able to spot the differences within 15 seconds? What you do is you cross your eyes. So magduduling kayo until you form a image in the middle. Okay? So we'll form a third image in the middle. And what you will see is that the differences will actually flicker. So the areas na may mga differences are the ones in red. So if you want, you can take a picture. Try ninyo. So you have your two images. Try to cross your eyes. You will until you form a third image in the middle. Okay? When you look at the third image in the middle, you will see that the areas kung nasaan yung mga differences, nag-flicker siya. So that's how you know the difference, no? And similarly with Alzheimer's disease and subcortical dementia, you might think it's similar, but you need to pay particular attention, maybe to change your perspective mo to see the differences. And with that, thank you very much for listening.
Thank you, Dr. Stephen Villaraza. And now let us welcome our fourth speaker, Dr. Donnabelle Chu.
Good afternoon. So naduling kayo sa picture. So let me start with the last topic for this module. So I'm tasked to give a lecture on holistic management of vascular cognitive impairment. So before I start, I would like to thank the organizing committee for inviting me to be a speaker for this afternoon. So as I've mentioned, I'll be discussing vascular cognitive impairment, or VCI, and specifically how we approach it through a holistic lens, where pharmacology, which was discussed earlier, meets lifestyle medicine. Because as we all know, there is no single drug that fixes vascular cognitive impairment, or VCI. The real question is, how do we combine what we already have, meaning the pharmacology, to actually change the outcomes? So just to orient everyone, we'll briefly look at the Philippine context, then go into evidence-based pharmacologic management, followed by lifestyle interventions with proven efficacy, which I would argue are often underutilized. Then I'll show a simple integration model and end with the practical strategies that we can all apply in our own settings. So I would like to overemphasize, this has been repeated by all the speakers for this afternoon, that when we say vascular cognitive impairment, it is not a single entity. It's really a spectrum from mild cognitive impairment all the way to vascular dementia. And in reality, most of our patients don't just have pure vascular cognitive impairment. It's often mixed with a neurodegenerative pathology such as Alzheimer's disease. So in the Philippine setting, what makes this more challenging is that we are dealing with high vascular risk burden, limited access to specialized care, and often the late presentation because of the rising burden in aging population. So this should shift our mindset from treatment to early detection and prevention. So these key risk factors in the Filipino populations are very familiar to all of us. Hypertension, diabetes, dyslipidemia, smoking, and physical inactivity. So which of these do you think has the biggest impact on cognition? So it was mentioned, it was discussed based on the mechanism and based on the prevalence. Hypertension has the biggest impact on cognition. And actually the key issue locally is not just its presence, but its control or the lack of control of hypertension. So we have to remember that vascular cognitive impairment is one of the few causes of cognitive decline that is actually modifiable. And if we intervene early enough, we can prevent progression to vascular dementia. So I will not be dwelling on this topic anymore because it has been extensively discussed by our previous speakers. But mechanistically, vascular cognitive impairment is quite heterogeneous. So we have large vessel disease caused by strokes, territorial infarcts, small vessel disease, just white matter lesions, lacunes, chronic hypoperfusion, and as well as microbleeds. Clinically, it's the small vessel disease that is really the dominant process. And that explains the phenotype that we see. So we see patients who have executive dysfunction, slowed processing, gait disturbance. So it's not just memory loss. So when a patient comes to us in the clinic or in the hospital with a memory complaint, but also has gait changes in gait slowing, or even just vascular risk factors, we should already be thinking beyond Alzheimer's disease and think of vascular dementia or vascular cognitive impairment. So again, the pharmacologic management has been extensively discussed by Dr. Villaraza, but we have to know the cornerstone of VCI management is aggressive vascular risk factor control. So by vascular risk factor controls, as I've mentioned, the risk factors of hypertension, diabetes, hypoperfusion. So in terms of pharmacologic management, we do have antihypertensives. So for hypertension, our target should be less than 130/80 blood pressure. And that in the SPRINT mind, it showed that a more intensive control actually reduces cognitive decline. Amongst the antihypertensives, it is the angiotensin-renin blockers, or the ARBs, and the ACE inhibitors, which are preferred for their potential neuroprotective effects. Amlodipine and perindopril combination has been shown to have reduced recurrent stroke and cognitive decline. But we also have to remember that we have to avoid excessive hypotension because it would impair cerebral autoregulation. For antiplatelets, aspirin is standard. Clopidogrel is slightly better in some cases, but we have also the dual antiplatelets for short term, especially for patients who had transient ischemic attack or minor stroke. And if there is atrial fibrillation, which is highly prevalent in our population, we should always give DOACs, and these are preferred as mentioned by the lunch symposium speaker earlier. In terms of the metabolic, so statins and other metabolic disorders, it's beyond LDL reduction. So statins have pleiotropic neuroprotective effects. So the Sparkle trial showed reduced recurrent stroke with atorvastatin post-ischemic stroke. And the pleiotropic effects of these medication contributes with the anti-inflammatory property, the endothelial stabilization, and the reduced white matter hyperintensities. So the target LDL level should be less than 1.8 millimoles per liter. In terms of diabetes, so metformin and type 2 diabetes has been shown to reduce dementia risk based on observational evidence. And that the emerging role of the SGLT2 inhibitors such as empagliflozin and dapagliflozin in cardiorenal and potentially cerebrovascular protection is worth watching because there are still ongoing trials with regards its benefits for the nervous system. So the takeaway here is simple. We have to control the vascular risk factors because if you don't control the vessels, you won't control the cognition as well. In terms of cognition-targeted agents, so this has been mentioned or discussed earlier as well. So again, this is just a table that summarizes the evidence of cognition-targeted pharmacotherapy in vascular cognitive impairment. Meaning these are the agents we consider beyond the vascular risk factor control. So number one, cholinesterase inhibitor, particularly donepezil, as mentioned, have modest but consistent evidence in vascular and mixed dementia. And this is the most widely recommended medication in terms of cognition. And in our setting, so donepezil has a lot of generics na, diba? And it is covered by PhilHealth. Next is memantine or the NMDA receptor antagonist. So it has, again, evidence, but primarily in moderate to severe vascular dementia. And it has a grade 2B recommendation. The nimodipine has been mentioned earlier. Cilostazol is particularly interesting for Asian patients with small vessel disease. It has an antiplatelet and vasodilatory properties with the CAST trial in a 2020 meta-analysis showing possible cognitive stabilization in lacunar stroke populations. So it is a reasonable consideration in appropriate patients. So we can consider giving cilostazol. Again, it has 2B recommendation based on Asian guidelines. In terms of ginkgo biloba and other vitamins, we have to be cautious about the benefits of these medications because, as discussed earlier, ginkgo biloba or EGB 761 has shown benefits in some trials, but the evidence is heterogeneous. And unfortunately, this is not endorsed by the AHA or the ASA, but it is endorsed by some Asian guidelines. And as mentioned, this is more for, it has been studied more for Alzheimer's disease rather than in vascular dementia. So again, the message of this slide is that the vascular risk factor control remains primary and is the core of management. Cognition-targeted drugs are just adjunctive. So again, we have to identify patients who are at risk so that we'd be able to control their vascular risk factor and prevent progression to dementia. Because again, these cognitive medications are adjunctive medicines only. So again, in our setting, we also have to think about the cost of the medications, availability, as well as adherence of patients. So again, we practically should prioritize BP control, diabetes control, before adding other medications because those give us the biggest impact. So again, based on evidence level, it's the statins and the antihypertensives with high evidence of level that would help in terms of giving benefits for patients with vascular cognitive impairment. So this, I think this illustration has been shown by the previous speaker. So again, this just shows there are a lot of medications or ongoing trials in terms of looking for possible pharmacotherapy for patients with vascular cognitive impairment or vascular dementia. So again, in this slide, the top half just outlines treatments with current evidence. And the bottom half outlines treatments that are still under development. So I'm not sure if you'd be able to see, but the mechanism for those under developments have something to do with neuroplasticity, angiogenesis, and the cerebral blood flow. So I won't be mentioning the specifics anymore, but you can see the slides. In terms of other symptoms of patients with vascular dementia or even vascular cognitive impairment, they commonly also present with neuropsychiatric symptoms, including depression, apathy, irritability, appetite change, delusions, and hallucinations. So as we always say in dementia, presenting with neuropsychiatric symptoms, it is the non-pharmacologic strategies that remains the first line of management. However, if the non-pharmacologic management is not enough, and if a patient who have depression, and if needed, it is recommended that we give SSRIs for depression. Now, for psychosis or agitations, antipsychotics seem to have some efficacy reducing agitation in all-cause dementia. However, there is no clear evidence for their specific effects on vascular dementia. And the application of antipsychotics should be given or should be approached with extreme caution given the adverse side effects of these medications, such as the extrapyramidal side effects, the increased risk of falls, stroke, pneumonia, thrombosis, and all-cause mortality. So I think we have to see that, we all see that in our practice, it's not just the memory loss, but it's the behavioral symptoms that really overwhelms caregivers. So addressing this is just as important. So you always have to look for neuropsychiatric symptoms in our patients with vascular cognitive impairment. Now we move to lifestyle medicine, which I think is often underemphasized. So I'll be presenting non-pharmacologic interventions with proven cognitive benefits. So there is a strong evidence for exercise, diet, cognitive activity, sleep, social engagement. So I'd like to reframe that this lifestyle medicine, these are not optional. This is actually the core components of treatment for vascular cognitive impairment or vascular dementia. So if we go to each of this one by one. So these lifestyle interventions are not just soft medicine. They have hard evidences, and in some cases, they have greater effect sizes than the pharmacologic management. So the first intervention is physical activity. So it is recommended for everyone, not just patients with vascular cognitive impairment, but especially those with vascular risk factor. 150 minutes of moderate aerobic exercise per week is recommended because it increases BDNF, it improves cerebral blood flow, and reduces cardiovascular risk. So the EXER trial in 2023 showed cognitive benefit even in established MCI. So we do recommend doing physical activity as a prevention, and even for patients with vascular cognitive impairment already, advocate physical activity. So for the diet, the MIND diet reduced Alzheimer's risk by 53% in prospective data. So components of the Mediterranean diet include leafy greens, berries, whole grains, fish, nuts, as we all know. But this Mediterranean diet can be adapted to local Filipino foods such as munggo, kamote, bangus, making it culturally relevant and affordable. So we have to also note of the DASH diet, so the combination of DASH Mediterranean, so it helps with the blood pressure control, as well as the cognition. It causes synergy in terms of prevention. Sleep, which we sometimes neglect. It's very important that we have 7 to 8 hours of sleep per night, because this hour is the optimal for cognitive health. So we also have to screen patients for obstructive sleep apnea, because OSA is widely under-recognized in our practice, but it carries 2 to 3 times the dementia risk. So if we see the profile of a patient, or we usually just ask them or do the OSA step bank questionnaire, so that we screen our patients for presence of OSA, so that early intervention with CPAP could also help identify early and reduce the risk of developing vascular cognitive impairment or vascular dementia. So cognitive reserve and engagement, so again, education, social engagement, lifelong learning. So we continue to learn things even if we get older, try to learn new things. We advise our patients that sometimes they would tell us, matanda na ako, ayoko na yan, tanda na ako, aanhin ko pang matuto ng computer. But we always have to tell them that they have to keep on learning, we have to keep on keeping their brain active, learn new things, learn new tasks, learn new hobbies, because this is a very powerful protective factors. So in terms of the Filipinos, so Filipino family structure and religious communities are genuine protective assets. In my case, I ask patients what their religion is. If they say that they are Catholic, I sometimes advise or tell them, oh, you can join groups in the church, yung mga seniors, yung mga couples for Christ, or mga Catholic Women's Association. Just join organizations to help them be more cognitively active. So again, the vascular risk lifestyle. So smoking cessation reduces stroke risk by 50% within a year, thus reducing the risk of vascular cognitive impairment. We have to limit alcohol to less than 1 drink per day for women and less than 2 for men. Weight management, so BMI of 18.5 to 24.9. Stress management, so it's hard during this time to manage our stress, but again, we have to do something to lessen our stress and learn how to manage it, because chronic stress affects the HPA axis, causing dysregulation. And again, for diabetes, a target of less than 7 of HbA1c is linked to a slower white matter hyperintensity progression. And lastly, social determinants and mental health, particularly depression. It must be treated aggressively, because depression and vascular cognitive impairment, it is causing a bidirectional and it can independently accelerate decline of vascular cognitive impairment. So you have to avoid social isolation, and overall, all these evidences of lifestyle medicine, physical activity, diet, sleep quality, cognitive reserve, vascular risk factor, modification, as well as social determinants and mental health factor. The evidence points to one thing: multi-domain interventions work better than a single intervention. So we should advise all of this, that if that individual can do all of these lifestyle change, it would really significantly prevent them to develop vascular cognitive impairment. So instead of thinking in just one or in solos, we have to combine pharmacotherapy, risk factor control, lifestyle medicine, as well as social support. And the effect is not just additive, it can be synergistic. So this is similar to multi-domain trials like the finger trial. So the message here is simple: don't choose between them. Don't just choose one. You have to use them all together to have a very optimal outcome. So this slide just shows what we can do. So the panel one, for screening and prevention options by stage of the vascular disease. So wala pang cognitive decline. So it's just the vascular risk factor. So no vascular disease, you have to watch out for cardiovascular risk of hypertension, lifestyle optimization, treat hearing and vision loss, cognitive stimulation, and avoid. If there is cerebrovascular disease, but it is asymptomatic, so in addition to the above management, you have to treat hypertension. So again, aim less than 130 systolic. Treat the diabetes, smoking cessation. Identify atrial fibrillation because we need to give anticoagulation. Antiplatelet therapy is not routinely recommended, and consider multimodal intervention. For symptomatic cerebrovascular disease, so in addition to the above, you have to add cognitive screening annually. So it is important to screen patients with vascular risk factors in terms of their cognition so that we could identify them early. And again, advise multimodal interventions. So if in the panel B, treatment options for those with cognitive impairment. So if there is subjective cognitive decline, optimize cardiometabolic risks, encourage cognitive and physical activity. Again, the multimodal intervention. So we could see that the multimodal intervention is present in all the panels. So for those with mild cognitive impairment, and if there is presence or evidence of depressed mood or depression, consider giving SSRIs. For vascular dementia, we start to give the Nepicil or the memantine and address the behavioral and psychiatric symptoms of patients. So in terms of the community-based strategy, so in the Philippine context, we really need to extend care beyond the clinic. That means training primary care physicians, tasks shifting to nurses. We have to involve or utilize barangay health workers for lifestyle counseling. So in even simple interventions like community exercise programs or caregiver support groups can have a meaningful impact. So we have to really educate and advocate these preventive strategies to healthcare workers, because vascular cognitive impairment management is not just medical, it's a social and community-based. So in terms of the community, we have to advocate community exercise programs such as Zumba for seniors and other group activities. So this is a simple framework we can all use. So number one, you have to screen and assess. So do cognitive testing, vascular risk profiling, stratify and identify modifiable factors. We personalize plan. So we combine medicine to lifestyle based on the patient capacity. And then we monitor and adjust, so follow up, modify management as needed. And we have to always have a support system. We have to engage the support system, engage family, and engage the community resources. So what's important is that this is simple, scalable, and doable even in primary care settings. So in summary, so just to sum up, we have to start early. Earlier intervention gives us better outcomes. So start vascular risk modification now. There is no single magic bullet. Holistic approach combining pharmacotherapy with lifestyle change. Blood pressure control is the most important modifiable factor. The Mediterranean Mind Diet shows strongest nutritional evidence. Physical activity and lifestyle interventions are powerful. Caregivers are essential and always screen for depression. And if there's one message I'd like to leave every one of us today, it's that vascular cognitive impairment is one of the most preventable causes of cognitive decline, but only if we act early and act comprehensively. So with that, thank you.
We sincerely thank our distinguished speakers for the breadth and depth of their presentations. The knowledge and perspectives shared today have shed new light on the complexities of vascular cognitive impairment and its management. At this point, we invite our audience to join the discussion. Please send in your questions through the QR code provided, and we will address them during the open forum. Or you may ask your questions live using the microphones placed around the ballroom. Let us now begin the exchange. Dr. Chu, I noticed that you were saying that you would want to optimize cognitive reserve. I was just wondering if the use of artificial intelligence now might have an impact. Like, is it going to adversely affect cognitive reserves, do you think?
It can be a benefit. Kumbaga, may advantage and disadvantage yung artificial intelligence. Sometimes it's just a matter of how we use artificial intelligence. Kasi diba, if we use it to help us, like sa mga senior nga, so parang tinatry nila to understand paano nila nagle-learn pa rin sila ng new things. So baka it can help them. And artificial intelligence can also be in terms of like yung mga apps nga, diba? In terms of yung mga cognitive games, there are apps with artificial intelligence now that we can use to help rin their cognition. The negative nga lang is yung iba na tinatamad na mag-isip because of AI. So we just have to tell them that use AI wisely.
Okay, thank you. We have a question for Dr. Villaraza. Between AD and VAD, which has a higher risk of BPSD, behavioral psychiatric symptoms, and does management differ for managing BPSD?
Okay, so that's a very nice question. So when it comes to the development of BPSD for Alzheimer's disease as compared to vascular dementia, actually both entities, both disease conditions can develop BPSD. It's just a matter of identifying when in the disease process the BPSD would emerge. So for example, in vascular dementia, in most cases, the behavioral symptoms would appear early on in the course of the disease. As I mentioned, aside from the executive dysfunction, attention problems, this might be accompanied by presence of emotional incontinence. For example, depression sometimes can be a heralding psychiatric symptom in patients with vascular cognitive impairment and vascular dementia. Now, so for vascular etiologies, usually the behavioral symptoms might appear early on in the course, whereas in Alzheimer's disease, it usually appears midway up until the later stages of the disease. So I think that's one way to, to at least differentiate if you're more leaning towards a diagnosis of Alzheimer's disease versus that of vascular dementia. However, there are, it's not impossible that the patient might have also concomitant Alzheimer's and vascular dementia, in which case sometimes the initial presentation would be that of a gradually progressive pattern of memory loss as in Alzheimer's disease, but then there might be interrupted by early behavioral manifestations as well. So in that case, if it doesn't follow the typical pattern, you might consider having concomitant pathologies for those cases. As for the management will be almost similar for the BPSD in Alzheimer's and vascular dementia. So it's just a matter of identifying what type of behavioral symptoms are present, because the treatment for BPSD is actually specific for a specific symptom of the BPSD. So there's not a treatment that will encompass all of the symptoms of BPSD at the same time.
Okay. Aside from addressing the vascular risk factors, I was wondering about the role of neuroprotectants. Like, usually we use it for stroke, after a stroke, right? How long would you normally use it for vascular dementia, cognitive impairment, or vascular dementia?
Well, as far as the studies for neuroprotectants are concerned, I think the only one that was mentioned in the study was cerebralizine. So that one they gave for a total course of 6 months at least. But then again, the caveat in that was that the studies mostly enrolled patients with vascular dementia, and it didn't really stratify what type of vascular dementia they have. So I think it might be, is that it might be beneficial for probably the multi-infarct or the strategic infarct dementia, but it might not be as effective for the subcortical type, because again, the mechanisms are very, very different for the large vessel disease versus that of the small vessel disease dementia.
Thank you. For Dr. Cenina, we were discussing the SVD scores now for prognostication. I was just wondering if there was an equivalent score we could use, say, using a CT scan, maybe because this would be actually more, in terms of availability, it's going to be a lot more available locally.
Well, ideally, as mentioned in the lunch info also, the gold standard really is the MRI. But of course, for all practical purposes, we won't delay imaging just because hindi pa magawa ng patient yung MRI. So a CT scan is more readily available, and definitely lacunes may be evaluated in the MRI, in the CT scan. An old infarct and old hemorrhages can be evaluated. Baka medyo limited lang po with regards the enlarged periventricular space and also the severity of the WMH. Although, in terms of the FASECA score for white matter ischemia, there is actually an equivalent po for CT scan. So we can still estimate, but of course, we will be more accurate with regards MRI.
Thank you.
Thank you.
When do you start donepezil for cognitive issues following a stroke? How early? Similarly for antidepressants in post-stroke depression. Would you like to take that, Dr. Villaraza? Or, yeah.
Okay. So I think, so this is a very, very interesting question. I think partly Dr. Cenina will be able to answer this because, again, we go back to the definition, the diagnostic criteria for vascular dementia. Following yung latest criteria, one of the things that they highlighted there was that the cognitive deficit should persist for more than 3 months. That's why it's very, very tricky to give a diagnosis of vascular dementia if within the first 3 months after a stroke. Okay? So if the patient has a stroke and initially presents with cognitive impairment, I think you need to monitor. No? At the minimum, 3 months. You have to monitor if there is the persistence of that cognitive deficit. And again, the treatment guidelines right now are more specific for vascular dementia. So you have to establish that there's persistence of the cognitive problems and that the cognitive problem is already having an impact in the activities of daily living of a person. So the patient already presents with a dementia syndrome. If that would be the case, then that's a time that you can start the patient on donepezil. Now, for antidepressants, this one is different because as what Dr. Donnabelle has mentioned a while ago, depression, in the context of vascular cognitive impairment, you should treat aggressively. So if the patient has symptoms of depression, even the early stages of post-stroke, I think it's reasonable to start them on antidepressants.
Thank you. Dr. Nolido, you discussed the various mechanisms for vascular dementia. I was just wondering about the role of antiplatelets for white matter mechanisms. Yes. Do you think there is a role for antiplatelets?
Yes, actually, it was a very good slide that was mentioned earlier that one of those antiplatelets are actually cilostazol. So as mentioned, one of the mechanisms is actually nitric oxide going down in the endothelial cells. So that causes vasoconstriction. A lot of thrombosis occurs and a lot of inflammation. And I think that one antiplatelet actually covers for everything as an antiplatelet, antithrombotic, and it causes vasodilation. So inflammation, tight junction dysfunction, I think is one target that everyone should also consider.
Thank you. Are there any other questions? If not, I'll be proceeding to the synthesis of our session. Okay, so just to summarize, I think our session highlighted that vascular cognitive impairment and vascular dementia is actually the most preventable form of dementia, and it's a call of action for us to be a little more aggressive in terms of addressing risk factors so that we can be more effective in prevention. It also highlighted the heterogeneity of the condition, meaning there's a lot of mechanisms involved, so we're going to have to employ a lot of interventions so that we can address all the mechanisms involved. We also discussed the various pharmacologic and non-pharmacological ways that we can employ to minimize the development of VCI and vascular dementia. So we are grateful to our speakers for the clarity and depth of responses and to our audience for the thoughtful questions that enriched today's exchange. The dialogue we've had underscores the importance of continued collaboration in understanding and addressing vascular cognitive disorders. As we bring this plenary session to a close, let us carry forward the knowledge and perspectives shared here to strengthen both research and patient care. On behalf of the organizing committee, I extend sincere thanks to our distinguished speakers and to all of you for your active participation. May you enjoy the rest of the convention and find inspiration in the sessions ahead.
Thank you to our speakers, Dr. Ana Marie Sage-Nolido, Dr. Alvin Ray Cenina, Dr. Stephen Villaraza, and Dr. Donnabelle Chu, and to our moderator, Dr. Maria Leticia Araujo de Jesus.